Okay, hello everyone. Today we're gonna show some several real hearts and as well as the three-dimensionally reconstructed heart of mainly adult disease. So let me start with one of the heart, HCMP, Hypertrophic Cardiomyopathy. Okay. The patient, as far as I know, this patient died sudden death. So autopsy was done. So we got this heart. So the heart was already cut by short axis. So let's see the causal piece of the ventricle. Maybe it's better to have a look at the middle portion of the ventricle. So this is the left ventricle, and this is a part of the right ventricle. Then you can, maybe this part is rather, the thickness is rather relatively normal, but when you see the other part, then markedly thickened, even trabecular portion also very thickened. So ventricular myocardium of left ventricle shows asymmetric regional thickening of myocardium. So that's the characteristic of a hypertrophy cardiomyopathy. If you look at carefully, then you can see some several whitish irregular area, which is a scar tissue. It's resulted from imbalance of the blood supply because the muscle is hypertrophic, as well as, in addition, the intramural coronary vessels are remodeled, so the wall of the coronary vessels are thickened. So there was imbalance of blood supply to make myocardial loss replaced by fibrosis.
Yeah, let me add some more on this specimen. If we dissect this muscle layer of the left ventricle and right ventricle is rather simple, but left ventricle has several different layers. It's not very clear-cut layers, but there are some direction of the muscle fibers have some difference from the end to the endocardium. So at the most endocardial layer is longitudinal, but in the middle it is transverse and spiral and so on. And here we see the marked thickening of the subaortic area of myocardium and shows some scar area. And we can barely see some vessels within this area. If you can, it's not, there are many vessels in the myocardium, but we don't see these vessels because in the contracted phase, the artery, intramyocardial coronary artery is also collapsed. So it's not really possible to see in this area. But we have three conditions to see these intramyocardial coronary vessels. One is this hypertrophic cardiomyopathy. The other is chronic rejection of transplantation heart, when the intramyocardial coronary arteries are atherosclerotic. And also in this, the hypertrophic cardiomyopathy, there are vessels within this area, and these vessels are sclerotic. And so that's maybe related to pathogenesis, morphogenesis of this area. You know the third disease that we can see the intramyocardial coronary arteries, pulmonary arteries are intact ventricular septum when the coronary cameral connection makes these hypertrophied area coronary vessels visualized. So these are the conditions. And when the surgeon remove this hypertrophy area to show in this this would be better or this is better, and here we can see anterior leaflet of mitral valve, which is the other side of the hypertrophied zone. So usually the hypertrophy zone is between the anterior leaflet mitral valve and subpulmonary area. So, the almost anterior part of the myocardium is markedly thickened. So if a surgeon removes this area, we can cut like this. So some superficial layer doesn't have any morphologic abnormality, but in deeper zone, we can see myocardial disarray, fibrous scar, and intramyocardial coronary artery with sclerosis. So these three are major histological abnormality we can recognize by after cardiac surgery to widen this area. And also, because of the jet flow has run this area with very narrow zone, we can see some endocardial thickening in this area. So those whitish area with the thickened endocardium can be a kind of a target indicator of hypertrophied zone to be removed. And also, sometimes the anterior leaflet of mitral valve has some the abnormality because in the ventricular systole, they are touch like this, so as to make a subaortic stenosis, and also some the valvar tissue with some thickening of endocardium and so on.
So the SAM and the hypertrophy make the obstruction must be serious. If anybody has any questions or comments, leave your message at the message column. Yeah, keep going on.
Yeah. Okay, maybe this specimen can show more easily the subaortic obstruction. So we made a cut. It's like a long axis view. So here is the aortic valve, and that is the mitral valve. So this is the upper portion of interventricular septum. Here you can see protruding interventricular septum toward to luminal side as well as the mitral valve. So when it in systolic phase, the mitral valve would be contact this area, so to make obstruction of a subaortic outflow part.
So we call systolic anterior motion, SAM, to describe this morphological change on video of left ventricular systole. And also we can recognize here the endocardium thickened in, yes, you can see the whitish endocardium in here, which is partly removed to examine histologically. And also we have to think about whether this subaortic obstruction is hypertrophic cardiomyopathy or some kind of morphologic change in the older age. Because most of the hypertrophic cardiomyopathy occurs in third and fourth decade, but when we see patients with similar to hypertrophic cardiomyopathy at sixth decade or older, we may think we have to think about it is not really hypertrophic cardiomyopathy, but senile subaortic hypertrophy. in that case, it's not related to genetic cause, but it's related to aging process of hypertrophy of myocardium. And the morphologic change is very similar in this area, but histological abnormality is not present in those senile.
Dr. Kim, will you speak a little more about the microscopic findings in Hong
Now?
Yes. There's something like a higgledy-piggledy appearance, something, no?
Microscopic finding of this area, we can first see endocardium with a thick fibrous tissue and normal subendocardial myocardium and myocardial disarray deep into this area, and fibrosis and intramyocardial coronary artery with sclerosis. These are the features we can recognize.
So as myocardial disarray as well? Yes.
Yeah. But myocardial disarray has to be cautiously described because the myocardial disarray is a very non-specific term, and it can be seen in the normal heart, in the septum, but very much abnormal myocardial disarray is present in the hypertrophic cardiomyopathy.
So it's not specific, but it's a more, how to say, it's marked. It present in wide area.
Yeah.
Like that.
So as we described hypertrophic cardiomyopathy as a pathology condition, but myocardial hypertrophy is another condition that has high thickening of the myocardial wall, in particularly in hypertensive heart disease and so on.
Okay, the measure heart. So this is the zoom out, please. Yeah. This is the three-dimensional reconstruction from the cardiac CT of one of the HCMP case. This one is the taken in diastolic phase, and only luminal side was reconstructed. So in this specimen, we cannot see myocardium itself, but here is the left anterior descending coronary, and this is the left ventricular lumen. So we can estimate the left ventricular myocardium. When you see this part, his thickness like this, but when it, as the Dr. Sa already mentioned, the anterior, the basal part of the left ventricular myocardium portion is thickened like this. Maybe.
And also we can see the aortic root. Aortic valve is of this size, and this is where mitral anterior leaflet is. And left atrial appendage and subpulmonary outflow.
Where is the mitral valve?
Mitral valve is in this plane. It is not shown here, but in between this, there is a space between left ventricular outflow and left mitral valve inflow in this zone.
Do you see the right ventricular outflow tract obstruction in hypertrophic cardiomyopathy too?
I don't think so. Anterior wall of it is more bulging towards the left ventricular area, not to the right ventricular area. I don't know why, but it obstructs subaortic part, not to the other way. So right ventricular outflow is very patent and very developed, but left ventricular outflow is narrowed at this zone here in this diastolic phase. Still is small, but in the systolic phase, in the same heart.
Yeah, the same heart, but in systolic phase. You can. So now is the cavity part of the left ventricle is small because it's systolic phase, and then you can recognize the much more thickened myocardium part here. So we can compare from the diastolic phase.
Yeah, zoom out,
Please.
More. Okay.
Yeah. Yes. So the thickness of the myocardium in diastole, like this, and then here in systolic phase, the ventricular myocardium is much more thickened, contracted in systolic phase.
So its ejection fraction is very good. This is diastolic volume and this is systolic volume.
Yes. Okay. Well, it's the same heart, but this one shows the long axis view. So this is the diastolic phase. So this is left ventricle and aorta. So we can see the patent subaortic outflow tract part. But when you look at the systolic phase heart, then the ventricular myocardium is thickened and mitral valve is anteriorly deviated, so it makes contact. So the subaortic outflow tract part is obstructed.
So it is patent here, but the aortic valve is closed at this diastolic phase. So the blood doesn't flow at this time, but blood flows at this time with this very narrow space. And the bulging of subaortic myocardium of ventricular septum is significant in this area, John. Maybe if we cut more anteriorly, it becomes thicker, because the subaortic, this is right ventricular outflow and this is right ventricular outflow. But the angle, if we cut more angular to this zone, it will be thicker than this. And so the systolic anterior motion of mitral valve is well shown here. But the mitral valve has to be closed at this time with very tightly anteriorly moved mitral anterior leaflet. So it's a very difficult condition for patients.
Okay, that's all for HCMP. So next, please.
Next specimen is a specimen from Sungkyunkwan University, Samsung Medical Center, and this is the large heart with hypertrophied, enlarged right ventricle with yellowish color. As you can imagine, this is very big right ventricle with tricuspid valve leaflet, and you already seen this right ventricle is totally replaced by fatty tissue, and also some fatty tissue are in the maybe. Yeah, you can see the difference of the color of the fat tissue here. Normally, there are some fat in the subepicardial zone, but these fatty tissue are very much limited to immediate subepicardial zone without any. This zone is usual, but as you can see, there are markedly infiltration of adipose tissue in this area, and also in this area it is normal. In the junction between atrium and ventricle is the atrial ventricular groove where coronary artery runs. So this is normal, but these are abnormal and these are abnormal. But more significantly, these are markedly replaced fatty tissue in right ventricle, which we call arithmogenic right ventricular cardiomyopathy. The original term was, as you know, the arithmogenic right ventricular dysplasia described by Italian group, and they described this kind of total replacement to myocardium by fatty tissue. We sometimes, if you examine more carefully, we may see some myocardial tissue in this zone, but here there is no myocardium almost. So, and also it produces much arrhythmia produced from right ventricular wall. So this is a kind of a more likely genetic origin, and the symptom of arrhythmia occurs in the second decade, third decade usually, and these are arithmogenic right ventricular cardiomyopathy. The anterior part of this right ventricle is also similar, but there are some muscles in this area, but totally replaced fatty tissue is seen in this specimen. Now you can recognize some muscle tissue by transillumination.
Dr. Seo, is it common to have LV fatty tissue in arteries RV?
Yeah,
Common finding, or?
We have not very much experience, but from this experience from the specimen of transplant heart, we can say that this kind of morphology is usual. So we may say the left ventricular arithmogenic left ventricular cardiomyopathy, if you don't see this part, but we don't think it is present only left ventricular myocardial dysplasia present. I don't know. So what we think as a pathologist is that if you have some endomyocardial biopsy in this specimen, it is very clear myocardium is dominant. But when there are in other conditions, even in case of myocardial infarction with fibrosis, there are still some fatty tissue ingrowth from the myocardium of the right ventricle. So presence of adipose tissue in endomyocardial biopsy of right ventricle doesn't mean it is right ventricular arithmogenic right ventricular cardiomyopathy.
Sometimes I have seen fatty tissue from rather old person. So it's also can be aging process to have a fatty tissue inside of the myocardium. So that's also possible.
And also hereditary dilated cardiomyopathy also has some fatty replacement of muscular tissue by progression of the disease. So
maybe the MRI or something like that can help us to how wide the fatty change is. Yeah.
Yes, exactly. So it is important to see the whole aspect of left ventricle and right ventricle to check how much is the adipose tissue involving in this heart. So MRI and other radiology process is much superior than the endomyocardial biopsy, which is only very much limited vision in this case. And also, we understand the fat tissue in myocardium has very much strange and curious function. So there are many suggestions that fatty tissue may produce some arrhythmia in different ways. Even in postoperative specimen of tetralogy fallow, the presence of fatty tissue may be a pathway producing re-entry or abnormal conduction process.
As a clinician, I'm reluctant to have the biopsy in this kind of patient. It's risky.
Yes.
Yeah.
Yes, it is risky, but we, by endomyocardial biopsy for adult, it is not uncommon to see fatty tissue, which we worry about the perforation of right ventricle. But in the normal situation, even the bioptome perforate the right ventricular myocardium, it doesn't make much tamponade because the pressure is not very much produced in that condition. Do you think so? Or? The other, I have never seen this kind of beautiful specimen of right ventricular dysplasia or right ventricular cardiomyopathy. Only Sungkyunkwan University, Samsung Medical Center has these two beautiful transplantation cases. So, and when was these two specimens taken? 3 years ago, or?
Yeah, I think 2 or 3 years ago.
2 and
yes.
3 years
yes.
ago. So it's important to keep this specimen available for a long time because it's not common to see this specimen. So in this specimen also we can see fatty replacement and fatty growth, thickening of right ventricle due to fatty tissue. And only limited subendocardial zone, there are some islands of muscle tissue in this area. And also by transillumination, we can see only some part of muscle, cardiac muscle is present. Some of them are not connected to each other, so they may produce some re-entry pathway. So one pathway is open, the other pathway is very narrow and so on. So
Dr. Kim, what was the clinical diagnosis of this patient?
When I got it, this already was diagnosed as ARVD. Yes.
So clinician already diagnosed,
네.
of course. Yeah.
Yes.
But why the ICD is not seen in this specimen? ICD has to be inserted when the ARVC is present. Maybe you removed?
Maybe, maybe, because we want to make a cut, so.
So yesterday, in the adult session, we discussed about the management of this condition. So ICD is absolutely important to protect from sudden death in this case. And even in this specimen, we can see fatty growth of left ventricular subepicardium, and some of the zone has some, So it's unusually thickened fatty layer in the epicardium is also present in the left ventricular side of myocardium. And so these are specimen. And also the other condition we differentiate from the ARVC is sarcoidosis. These are the specimen taken from transplantation due to sarcoidosis we suspect. I mean, sarcoidosis is very difficult to diagnose because in the autopsy experience, sarcoidosis is very clear. In autopsy, sarcoidosis has a very much strong, dominant granulomatous condition in the myocardium with visible granulomas and so on. But in clinical case, it's not that clear. That means sarcoid granuloma disappear very much after the treatment. So steroid and the medical treatment removes granuloma, histological granuloma easily. So in this conditions, we found we had endomyocardial biopsy with granuloma, so we diagnosed it already before transplantation. But after transplantation, we couldn't find additional granuloma, but very much tiny granuloma-like lesion were only we could see. But what we could clearly see was the multifocal fibrous nodules. And that size of the individual fibrous nodule is much bigger than any other condition. And the distribution of fibrous nodule is not related to coronary arteries. That is a characteristic of this sarcoidosis, and that is suggestion of the raw multifocal granulomatous lesion in this area, which disappeared and scar is remaining after treatment. So, and also in this right ventricle, we can see exaggerated subepicardial fatty tissue, but subendocardial zone, there are significant amount of myocardial tissue in the sarcoidosis. That means this fat tissue is probably related to this condition, and maybe this may be additional part, but the replacement of myocardium by fatty tissue is not that clear compared to arithmogenic right ventricular dysplasia. So I suspect this fatty growth of the right ventricle may be related to some myocardial death, and some they can stimulate fatty growth, but the myocardial loss in sarcoidosis is not that severe as is in the arithmogenic right ventricular cardiomyopathy. This is another example of sarcoidosis. In fact, I filled silicone to show red color silicone to show coronary artery and black color silicone to coronary sinus. But after I cut this specimen, the silicone, the anatomy of silicone doesn't really necessary. Much more importantly, this has a classical sarcoidosis case of transplanted heart. So as you can recognize, there are multifocal fatty fibrous scar in the myocardium, middle subepicardial, subendocardial, and distribution is not related to coronary artery. And right ventricle is dilated in this case, and myocardial loss is severe in right ventricular myocardium, which that is much more severe, much severer than the previous case. So myocardium is replaced by fibrosis and fatty tissue, but fibrosis is dominant and fatty tissue is additional. So if you make endomyocardial biopsy of this specimen, we can see fibrous tissue, myocardium, and fatty tissue in this heart. And the distribution of this granuloma suggested in some researcher that it may be related to conduction system, but we don't see any specific relation to conduction tissue in this granuloma, but the random distribution of myocardial granuloma can involve the His bundle and major proximal bundle of left ventricle, so that can be related to clinical syndrome in sarcoidosis. So in the endocardium, we can see multifocal scar. And so by endomyocardial biopsy in the right ventricular septum, we will biopsy this zone. So in this zone, we can see fibrous scar and some fatty ingrowth and myocardium, but and in the parietal right ventricular wall, we can also see some fatty tissue in this specimen. So it's not really possible to differentiate these two conditions by endomyocardial biopsy. That has to be done by clinical imaging modalities. This patient was 56 years old woman with history of operation for tetralogy fellow. So subepicardial pericardium, visceral and parietal pericardium are adhered due to previous operation. And also there are some suture material in the subepicardium which represent previous surgery due to tetralogy fellow. And also in this case, the right ventricle from outside is dilated and left ventricle is not very much dilated. By sectioning this heart, we can see diverticular anterior extension of right ventricle, and this part represents some right ventricular failure, and also pulmonary valve is dystrophic, so it has some long the problem, but not very much significant. It's a significant problem in this condition. So endocardium is markedly thickened due to this inflammatory and physiologic process of pressure in the right ventricle. And anterior wall is totally replaced by fibrous tissue and fatty tissue in this case. And the tricuspid valve has regurgitation, and the surgeon has already inserted tricuspid valve ring to reduce the tricuspid valve regurgitation in this case. But as you can imagine, 56 years history of her cardiac condition could produce significant number of complications of heart function, but still it is good to have no problem in pulmonary hypertension, not significant pulmonary hypertension. So it was possible only heart transplantation can prolong his healthy living. And this is left ventricle with mitral valve, and septal surface of left ventricle is a little thinner than the rest of the myocardium, and maybe some the left ventricular systolic function is reduced to have dilated clinical syndrome of dilated cardiomyopathy. So it could produce decreased cardiac output and also some dilation of mitral valve ring to produce some functional regurgitation of mitral valve. And finally, the clinicians decided to, clinicians in Sejong Hospital decided to.
Can you see any myocardium at the free wall of RV?
Yeah.
Next
This
to the
part has
myocardium
around here. No myocardium.
Yeah, there was a.
No, the lower part, inlet portion.
This
Here.
part?
This part is, I think, it's
Yeah.
maybe above the atrial
This part is
junction.
atrial ventricular junction. This is immediate tricuspid annulus. So I'm showing like this. So this is right ventricular free wall, and there are muscular tissue in here. So right ventricular inflow part is normal, and
Looks like
trabecular and outflow
in there between tricuspid valve.
tricuspid valve,
Yeah.
and this is ICD electrode. Yesterday, Professor No Jung-il sent me a question about how to evaluate how much is the myocardium present and how much is lost. So I thought it is a good question, but still, it's not possible to say where we examine. It depends on where we examine. So in this area, there is no cardiac muscle, but in this area, cardiac muscle is significant. So probably we can imagine some good indicator of degree of myocardial loss in this case, and probably at the present absence of the apical myocardium is a result of significant functional disturbance. That means it's kind of an aneurysmal thinning of myocardium in the apex, which means there are significant functional disturbance in this right ventricle. So my answer was, maybe we can say if the apical myocardium is very thin, it's not really possible to restore the right ventricular function. And also, if you have another option, we may say the replacement of pulmonary valve again and reduction of right ventricular size to remove this kind of aneurysmal anterior right ventricular wall. Maybe Dr. Kim Kyung-hee, and you have a comment? Yeah, if you have a comment, please come and give some.
Use the microphone. Yeah. We can't hear you. Yeah.
Can you come here and to say? So it was treated by cardiac surgeon and pediatric cardiologist, and now it was treated by cardiac.
Yes, that is a really good question. And actually, we have discussed this patients a lot of times with surgeons. Actually, by the echocardiography, it shows the severely RV dysfunction, and then severe TR, and also LV shows severely dilated, severely diastolic dysfunction due to the pressure and volume overloaded of the RV. So in the first time, I suggested if the patient got tricuspid valve repair and then pulmonary valve replacement. However, most surgeons, and also I thought if the surgery if the patient got surgery, the RV cannot tolerate after the surgery because of the very thin RV and then the very RV dysfunction. So we thought if she got tricuspid valve repair or pulmonary valve replacement, and then after that she might be dead. So we already had a case, the similar cases of TOF. So after that we got heart transplantation. So in this case we did not decide to get tricuspid valve replacement. Instead of that, we decided to get heart transplantation directly. And actually, she got infused the vitamin for a long time, maybe 6 months, for get a heart transplantation. So we don't think the RV can tolerate from the tricuspid valve replacement or repair.
So, thank you. And how old was the patient?
Yeah, she got dyspnea and then also.
No, I mean how old?
She's
56.
She's 56 years old, and then heart failure symptom for about 5 or 6 years. And actually, when I worked at Bucheon Hospital, I already discussed this case several times, but many surgeons didn't want to get surgery.
Thank you. Professor, Have you ever seen the so-called Orr's anomaly?
Ur's anomaly.
Yeah. But this case has a formed tricuspid valve, so it's not Orr's and old enough. Yeah.
Yeah, Ur's anomaly is a kind of congenital condition.
Yeah.
But it is like Ur's anomaly, almost total absence of myocardium in right ventricle.
But they usually do not have a formed tricuspid valve.
Oh, right.
But
So how was the left ventricular function in this case? Was that okay?
Actually, the systolic function was around 40%. However, because of the RV volume overload and pressure overload, LV shows a restrictive pattern of diastolic function. So the systolic function was mildly reduced. However, restrictive pattern of diastolic dysfunction. So it says this LV did not function very well.
So restriction of left ventricle in diastolic phase may related to dilatation of right ventricle.
Yes,
Yes.
right.
So the pericardial cavity is totally filled with big right ventricle. So left ventricular dilatation is.
And then the right ventricle is like a paper-like thing, right? Yeah. So after I don't think the echocardiography. After the tricuspid valve repair or replacement cannot, the RV cannot tolerate by the surgery, I think so.
thank you.